Good afternoon. First of all, I'd like to thank you, Dr. Sclafani, for the invitation, for the possibility to present our work. I'm coming from Bulgaria. I don't know if you know where it is. It's in the southeast Europe, very close to Greece. So it's this is some pictures of my country. It's a small country that is very nice and very beautiful. And this is our hospital. Our hospital is a Japanese hospital that is part of one of the biggest medical corporations in the world. This is the Tokushukai Medical Corporation. And this is the first overseas hospital of this corporation. We conducted, in fact, a registry of CCSVI endovascular treatment. We started in January. And I think that it's clear for all that there is a very close relationship between CCSVI and the multiple sclerosis. It was proven since the works of Charcot. And so I think that the only question is how to maintain well the veins, and maybe most important, how to maintain the result, so to prevent the restenosis. We, until now, starting from January until the last week, we have done 214 consecutive patients with balloon angioplasty and stenting. And in my presentation, I included only patients with at least 1 month follow-up. So there were patients until included in the registry here in the interim results until 15th of June. The follow-up was by means of Doppler independent neurologic evaluation and quality of life questionnaire. And what about the population? In fact, these are all the patients that signed the informed consent to use the data. And it's very interesting that these 158 patients represent 99% of all the patients that were sent from my colleague, Doppler specialist colleague, Professor Gruzdinsky, with evidence of some pathology, venous pathology, stenosis, reflux, and so on. And we had followed until now. The protocol includes 6-month follow-up, including MRI, but until now we had a full follow-up for 1 month of these patients. I mentioned the Doppler findings. During this time period, 177 patients with clinically established multiple sclerosis were revised by Doppler. And in fact, 89% of them, so 159 of the patients had some venous pathology. They were involved by the classification of Dr. Zamboni. You see that all the 3 veins were involved in 81% of the patients. And the range, the youngest patient was daughter of a friend of mine. I'm going to show the case after that. And they were predominantly female, like in the study of Dr. Sinan. And there were patients from all over the world, from 12 countries, not only from Bulgaria. What about the clinical presentation? Half of the patients were relapsing and remitting form of MS, and the other were primary progressive 16% and secondary progressive 30%. The EDSS score evaluation, the mean EDSS was 5.2. What about the interventional procedure protocol? Shortly, we puncture right or left femoral vein with 8 or 9 French terumo, short terumo introducer. I'm a cardiologist, and maybe because of that, we consider, with the cardiologists, we consider that with the Judkins Wright catheter we can do everything, and it's almost a fact. So I use mainly Judkins Wright, but also I use the Cobra sometimes, especially for the diazygos vein, because sometimes it's very challenging to get selectively into the diazygos vein. So we are using mainly the Judkins Wright 5 French catheter in first in AP, anterior-posterior position, at the level of the carina, and after that turning the tube on the lateral position, I'm trying to find the diazygos vein, and we are using called the Stork wire 035, or a little stiffer wire that is the supracore, Abbott vascular, or in rare cases we use Amplat super stiff. If stenosis or impairment of flow is present, twisting and so on, some pathology, we are proceeding with ballooning of the diazygos vein. In most of the cases, because many times I start quite distally, because of that I start with a smaller balloon, 6-7 millimeter, to reach many times in male to 10-12 millimeters balloon at the place of the valve. And the most challenging step is maybe to introduce the balloon, because you know the trajectory of the diazygos vein is just reverse to the cava, to the superior vena cava. Okay, after that we are dilating many times. If we need to dilate 20 times, we dilate 20 times, not only once. And after doing a good post-dilation angiogram, we proceed with the jugular. With the same Judkins Wright, we are proceeding in AP, or in a slightly lateral left oblique position, 15 to 20 degrees. I search the left jugular. Generally, I start with the injection of contrast from distal, just below the bulbous, to the proximal. So I'm doing 2 or 3 injections in order to see all the trajectory of the vein, because many times, more than 50% of the times, not only we find pathology not only at the place of the valve, and not always correcting the valve stenosis, the stenosis at the upper part disappear. I'm going to show you after that very, very resistant stenosis. If non-satisfactory result is done with the semi-compliant balloon, we use scoring balloon, and we use mainly the angiosculpt from Biotronic, and in some cases the cutting balloon from Boston Scientific. And as a third step, if really non-satisfactory result is done with the scoring balloons, with kissing balloons and so on, we are using stent. I would say a little more as a routine practice than the other groups. In all the cases that we implanted stents, we implanted a protégé that is very important, non-balloon expandable stent. It would be a mistake to implant a balloon expandable stent, because the diameter of the balloon expandable stent is a fixed diameter, and the diameter of the vein is very dynamic. So it depends on the breathing and all in many conditions. And this is maybe one of the reasons many to be afraid about misplacement and migration of the stent. But implanting nitinol self-expanding shape memory stent with a good oversizing, at least 15 to 20%, the possibility of migration is very, very low. We didn't have no one patient with migration of the stent now. The implantation, the process of implantation is very important. It's low jumping stent. If you implant the stent very slowly in order to allow to the stent to position well over the wall, the vessel wall, the probability of jumping is practically zero. What about the diameters of the stents? We are implanting mainly between 8 and 10 millimeters in the azygos and between 10 and 14 in the jugular veins. It depends on the level, of course. The anticoagulant antiplatelet protocol is very important. It's a cornerstone of the protection from thrombosis, of the prevention of thrombosis. Our initial experience, mainly with stenting and extrapolating data from coronary cases with double antiplatelet therapy, so clopidogrel, Plavix, and aspirin, was not very positive. We had a couple of stent thrombosis that they were successfully redilated with fibrinolysis and additional ballooning. After switching to another protocol that uses more liberally anticoagulation with the new anticoagulant that is direct anti-10A agent, dabigatran, with this is the brand name in Europe, Pradaxa. It's for the audience, it's similar to Coumadin and Warfarin, but it doesn't need any control, any monitoring. And this is the usual mid-dose. It's from twice per 110 milligrams to twice 150 milligrams. And in almost all the patients, we are giving twice 110 milligrams. And we don't have, after this protocol, we have only one stent thrombosis out of more of 40 stents implanted. And of course, aspirin. The overlapping with heparin, at least for 12 hours, is very important. So post-procedure, we are using heparin with the dosage of between 500 and 1,000 units per hour. What about the angiographic data? We have done balloon angioplasty of all the stenotic lesions, and in 71 of the lesions we had to implant stent because of non-satisfactory result, or this is the percentage is 8.6% per lesion or 44.9 per patient. Besides of that, we've done additional study that is a sub-study of our registry about comparative blood gas analysis in jugular and femoral veins in healthy controls in the MS group. What was the background of this study? The chronic inhalation of air with elevated concentration of carbon dioxide and low concentration of oxygen lead to symptoms very similar to the chronic symptoms in multiple sclerosis, namely dizziness, headache, fatigue, impaired and double vision, cognitive dysfunction, dysarthria. In rest conditions, in fact, in healthy subjects, the oxygen tissue consumption and extraction is not very different in the brain and into the other organs. So in rest conditions, there is no reason to have big difference between jugular gas analysis and femoral gas analysis. The other reason is that the immediate improvement that we have seen many times on the table, on the surgical table, has no many explanation. And we assume that the possible very fast gas analysis and gas exchange improvement can lead to this very fast neurologic improvement also. Okay, we conducted the study. Our research included a total of 55 patients, not very big group. We had 38 patients with MS, and we took gas analysis only from diseased veins, so only from veins that had stenosis more than 50%. And we had a group of healthy controls of 20 patients. The samples were taken under standard conditions, of course, and after good flushing of the catheter. What were the results? In the MS group, there was significant difference between the jugular and the femoral gas analysis in terms of hypercapnia, hypoxemia, and deep desaturation of the veins that were involved in the CCSVI. On the opposite side, in the control group, there was no significant difference between two sites, between the sites of jugular veins and the femoral gas analysis. And it's very important that not only absolute but also relative difference between the group of MS and between the control group was statistically significant concerning all the three signs: the CO2, oxygen, and also saturation. And it's our big hope was that after the procedure, the control gas analysis after the procedure, after the liberation treatment, will be very, very different from the beginning, from the baseline. It was not so different. There is some difference, but it's not very big. So the hypercapnia is improving. Also the saturation is improving, and also the partial pressure of the oxygen is improving. It's maybe not so fast process, because we were taking the sample just immediately, literally seconds after the ballooning. And it's maybe necessary to wait a little, to wait 10 minutes, maybe 1 hour, 2 hours, nobody knows. But we are still in this job. So as a summary of this sub-study, I would say that compared to the femoral vein gas analysis, in the multiple sclerosis group, the jugular vein gas analysis shows an unusual difference consisting of hypercapnia, hypoxemia, and desaturation of the venous blood. Similarly, if compared to the control group, the CCSVI group is remarkable with the same, with hypercapnia, hypoxemia, and desaturation. And the interventional treatment leads to mild, immediate reduction of the gas exchange disturbances. There are some limitations of the study: very small group of patients, different number of patients in both groups, and lack, as I said, lack of remote and follow-up samples. There are many questions that can be asked. First of all, does the difference between femoral and jugular gas analysis come to normal limits in the time, and when in these patients? Secondly, are the immediate improvement on the surgical table in some patients is related to more pronounced immediate improvement in the blood gas exchange? Is it possible to use the normalization of the blood gas exchange as a marker for successful intervention? Will the normalization of the brain blood gases remain in the follow-up period in case of patent veins, and can this be considered as a sign of restenosis? And is the blood gas impairment direct function of the impaired flow, or there are other factors contributing to impaired gas exchange? What about the big group? We had treated in almost all more than half of the patients had pathology in all the three veins, as I mentioned before, and because all the three veins were treated. This is the balloon angioplasty group. This is the percentage of stenosis in vascular territory, in the different vascular territory. And these are the mean diameter of the balloons that we had used. The mean diameter of the balloon in the azygos was slightly less than in the jugular. As Dr. Sinan said, in the jugular vein at the place of the valve, we use sometimes very big balloons, 16, 18 millimeters, and it's normal. Because of that, the mean diameter of the balloon is bigger in the jugular veins. This is the diameter again. It's the same, but in a diagram. And this is the relative distribution of stented lesions. As Dr. Zamboni mentioned in his study, the azygous vein is less prone to have restenosis, and also there are less resistant stenosis in the azygous vein. And because of that, maybe in our group also, less stents are implanted in the azygous vein, because in most of the cases the result, the angiographic result, is very nice only with ballooning. And the other comparison is interesting, that in our group resulted that the more the lesion, the percentage of the lesion is, the more probably is to need implantation of a stent. And always we implanted only one stent, absolutely by purpose, in order not to mislead the analysis after that. And the mean diameter of the stent, as I mentioned, similarly to the balloons, bigger balloons, bigger stents were implanted into the jugular veins with oversizing, as you see, compared to the balloons, and little smaller balloons into the azygous vein stents. Sorry. So the final procedural result, in most of the cases we succeeded to have good flow and very low residual stenosis rate. What about complications? It's very important, as Dr. Salvi said, this is a very low complication rate procedure, very low. We didn't have no one big complication that to need surgery or additional intervention. In a couple of cases with this quite good anticoagulation regime, we had some local hematomas in 3 patients and some mild extravasation without any clinical significance. In 2 patients we had acute renal failure without the need of hemodialysis, not requiring hemodialysis. As Dr. Sinan said, sometimes these procedures last 2 hours, 3 hours with a lot of contrast. So we had to have in mind that this is a sometimes very high volume of contrast procedure. What about the clinical course? The in-hospital clinical course was quite promising. Most of the patients improved, some of them really over the table. The patients, because I use very mild sedation and some painkillers, many times the same patient telling me, without asking him, telling me about the improvement that he feels in the vision, in the feeling of legs and arms and so on. More improvement had the patients with EDSS score below 6.5. What about the follow-up? As I mentioned, we had a full follow-up only for 1 month for this group of patients. During this follow-up, we had 18 cases of restenosis, and 10 cases were treated with redo PTA, successful PTA, and in 4 cases we had to implant stents because of the restenosis after balloon angioplasty. As I mentioned, among the stented group, in the beginning we had a couple of cases of acute thrombosis. We had 5 cases of acute thrombosis under a double antiplatelet regime. Evidently the extrapolation from the coronary cases is not suitable, and because of the flow in the veins is very slow, we need anticoagulation, real anticoagulation, but not antiplatelet. And because of that, we switched to the new regime. With the new regime, only 1 case of acute stent thrombosis was evaluated, and almost all the cases of in-stent thrombosis were redilated with the strategy that I explained, with supraselective fibrinolysis, additional ballooning, absolutely successful. In 1 case only, it was not successful. Okay. What about the follow-up? In most of the patients we had improvement. We had improvement in 88% of the patients, clinical improvement, and no change in 7% or worsening in 5%. It's interesting that among these 10 plus 8, 18 patients with, in fact, not very favorable result in the follow-up, 90% of them had a restenosis. As Dr. Sinan said, it's a very, very good sign of restenosis is non-improvement. Several cases. Just a couple of cases. It's a case of a 54-year woman with quite elevated EDSS score, 7.0. He had, in fact, totally occluded azygos vein, and this is the injection at the place of the valve. At the place of the valve, we had to use. We always use hydrophilic terumo wire, but in this case it was not possible even with the hydrophilic terumo wire to cross the valve, and because of that we used coronary materials with O14 wire, again hydrophilic, that is a whisper from Abbott Vascular, and hydrophilic balloon, that is over the wire balloon, real gym balloon, 1.25, very small balloon, really. And with this strategy, we tried to cross the valve and to dilate gradually with coronary balloons, step by step, and finally finishing with the 8 per 40 millimeter ever cross from EV3 balloon at 10 atmospheres, with this very good final result, with very good restoration of the flow, no collaterals. This is another case, but you see it's in the upper part, in the proximal, in the distal part of the vein. It's a very tight stenosis just below the bulbus. It was not possible to be dilated with even with scoring balloons, with angioscoped, and because of that we implanted a stent. We implanted a stent before the injection of contacts is seen, the stent here, the mesh, with a very, very nice result. Another case, this is, I have shown some complicated cases. This is a stent thrombosis in a young woman. The stent was implanted 2 months before the index procedure, and this is the injection of contracts that is showing very well the thrombosis of the stent and below the stent. Why the stent thrombosed? Maybe because of this stenosis that from the first intervention was not dilated properly, and the stent was above. Evidently, most probably, the blockage of flow and the turbulence here caused the stent thrombosis. So it's very important to look all the trajectory of the vein and to repair all the lesions, all the stenosis when implanting a stent. We had, the stent was very easy to open. The stent was very easy to open and to inject the Actilis, the fibrinolysis. But it was very difficult to open this stenosis below the stent. We had to use kissing balloon with angioscope, with a scoring balloon, in order to dilate this stenosis at very elevated pressure at 20 atmospheres. Finally, we succeeded to recanalize the stent and to improve the flow. And in the follow-up, the flow in the vein is absolutely normal. There is another patient. I wanted to show you that if the stent is implanted properly with achievement of good vascular result and good flow, the result of stenting is very nice. It's absolutely uneventful. After in the follow-up period, you see here the stent implanted is very nice 3 months after the implantation. Okay, so take-home message for this case about stenting. As a strategy to improve the results, I would say that we have to fully dilate and restore the flow in all the lesions of one and the same vein, not to restrict ourselves only to one stenosis. Significant residual stenosis carries the risk of late thrombosis, as you have seen, and the highly resistant stenosis can be usually successfully treated with non-compliant balloons. And I want to show you another case. As I mentioned, one of the patients, the youngest one, was the daughter of a friend of mine. She's 22, she's doing very well now. You can see the contrast is staying here and it's not going down, you see? It's not possible to go down. It was almost totally occluded at the middle portion. It was very, very tight stenosis. You see the indentation, it's a high pressure balloon, and there is a very deep indentation in the balloon during the inflation. After, this is the intermediate result, it's something. At least we have vein now, but I didn't like this site, and because of that I implanted a stent there. And this is the moment of the implantation. As I mentioned, we have to implant the stent very slowly in order to allow the stent to have a good apposition over the vessel and to fix well in order not to move. And this is the final result with a full restoration of the flow in the vein. Fortunately, the girl now is absolutely healthy. And with also with no lesions and no active lesions at the MRI. Some conclusions and future perspectives. Our preliminary data confirms published findings. Clinical improvement in the group with preserved vascular result, it's very important, and worsening or no improvement in the group with the unfavorable vascular result in the follow-up. Stenting with achievement of optimal vascular result under strict anticoagulation protocol can be an alternative of balloon PTA, especially in resistant and non-dilatable lesions. The data presented are registry of consecutive patients, and it's important that the intervention decisions, PTA or stenting, was done not only by clinical and vascular science, but also by preferences of the patient. And further structured and systematic information is needed, so we need a randomized controlled trial. We have designed such a trial with the help of the Reformed Multiple Sclerosis Society, and we are waiting for the approval from the National Ethics Committee in order to perform a routine stenting study compared to control group with only medication. We are going to include 240 patients, 180 in the stented group and 60 patients in the control group. And we are going to follow up two primary aims: MRI data for active gadolinium active lesions, and secondary EDSS scale differences between the two groups throughout the study. And of course, very important, one of the secondary purposes, stent and vessel patency rate at 1 month, 6 months, and a determination of the study. A couple of slides about I'm inviting you to our vascular course, the second endovascular course that is going to take place at the end of November in Sofia, in our hospital, in Tukuda Hospital. And this is the site of the hospital that you can register yourself for participation. It's free of charge. And okay, I'd like to thank you for your attention.
Thank you, Ivo. We have any questions?
Did you segregate out the data for the primary prevention and secondary prevention patients? There's been a lot of discussion about they respond as well.
Yes, we did some analysis, and we have the impression that the RR form is with the best results. So the relapsing remitting form is influencing better from the treatment. But my opinion is that in fact there are no forms of multiple sclerosis. My opinion is that there is a chronic phase that is very much influenced by the gas exchange impairment. This is the chronic phase: fatigue, double vision, problems in the balance, and active phase when the immune system is activated. So all the forms that the neurologist describe are a mixture of these two processes. And I think that it's one and the same, and maybe most important that the reason, my opinion, is that the reason is primarily really vascular.
Middle?
Very concerned about your liberal use of stents in the venous system. As you know, with dialysis access and placing nitinol stents in subclavian and non-neck veins, their patency is less than 50% after a year. So I won't be surprised that in a year or so, most of these patients develop pneumococcal hyperplasia. And I caution you, before you start your stent study, you may want to follow these patients at least for a year, especially if you're the jugular vein, there is a valve which is resistant ratio, and then you do a 4 or 6 or 8 centimeter stent throughout the jugular, and if you thrombosis, you are going to be losing all the collateral, and the patient may be worse off in a year or so. So that's...
Yeah, you're absolutely right, because our strategy during the registry was to implant stent only after convincing ourselves that it's not possible to dilate the lesion. I'm not sure that the risk is so big, it's so high, but okay, the follow-up will show.
Yeah. To what do you attribute the high yield of your screening with so many patients with disease? That seems to run counter to some of the other things. You have a very high yield of lesions for those screened. Do you think it's aggressive screening, selection bias in some other fashion? I would also make one other comment about the comment here about venous stents. I'm not sure I agree either with the gentleman there. They've been patent in non-stressed areas, that is the iliac veins, for quite longer than we thought. So I think it's a bit safer than some of the concerns. But anyhow, the principal question about your yield of screening.
I think that is maybe a matter of criteria to find or not to find stenosis on a vein. If you use properly all the 5 criteria of Dr. Zamboni, and if the investigation is done by an experienced operator, experienced Doppler operator, I think that pathology will be found in more than 90%.
Yes.
I had a question related to your technique versus Dr. Sinan's technique. Correct me if I'm wrong, but Dr. Sinan was just angioplastying the valves, and that the higher stenoses were left untreated and were improving from what I earlier heard. But you're treating everything. I think both of you guys can speak to this. Dr. Sinan, were you seeing the same kinds of tight stenotic mid-distal jugular lesions that when you just treated the valve, they just disappeared, after delayed observation? And then, is there a philosophy we should be standardizing, as opposed to 2 different ways of dealing with it? I don't know.
Yeah, well, we're seeing the same lesions, exactly in the same place. The thing is that it's very difficult for an interventional radiologist when see stenosis to be developed. But we have convinced ourselves that this is the way to go, and we have proved that by 2 methods. By actually doing the valve treatment and then leaving this lesion on and coming back an hour later when you have finished the treatment with the other things and rechecking it. And with doing that, I would say 80% of the time, the residual 20%, which perhaps the breakdown is treating, we're quite confident that that's not the case, because when we leave these lesions alone, then the next day when we do the ultrasound, these lesions are disappearing. So they disappear anytime from 1 hour to 24 hours after the procedure. And I have full confidence on my vascular ultrasound physician and his ability. And, you know, he's so good that he's now done 400 MS patients that after the 24 hours post the procedure, the vein is absolutely normal in all the 3 areas, J1, J2, J3. Okay, so we're quite confident that that's the way to go, is not to touch the lesion. There may be some residual lesions that we might miss, but I think that the number is insignificant. That doesn't warrant the treatment at this higher lesion with the possible complication, because the higher up you go and using balloon angioplasties, the more risk you will get with things like dissection, extravasation of contrast, and, you know, possible and all different possible kinds of complications.
In fact, because maybe we are not going to have enough time for the case presentations and so on, I wanted to show you a case, but it's not active now. Yeah, okay. I wanted to show a case that you are going to realize that if you open perfectly the valve, this vein is not going to be working. Just a second. Yeah. Okay. So you are going to see here, it's practically total occlusion of the vein of the left jugular just below the bulbous. Just below the bulbous. It was very difficult to cross with a wire. Okay. Sorry. Because I had prepared several cases. Yeah. And I'm gonna show you. Yes, this is the one. Okay, you can see very well that the contrast is going into the middle segment, but doesn't go further into the distal part. We had to cross the lesion with a 014 coronary wire, that is a chronic total occlusion wire, dedicated wire for chronic total coronary occlusions, Asahi Miracle 6. And this is the balloon inflation. This is in fact the second balloon inflation. The first balloon inflation was with a 2 millimeter balloon, and over the 2 millimeter balloon there was an indentation. So this is the second inflation with a 5 millimeter balloon, after that with a 6 millimeter balloon, in order to succeed and to open the vein. You see, now the contrast is going not only into the middle part, but also it's opacifying the sigmoid sinus. So in such case, it's absolutely impossible to have a good result if even open very well the valve. It's true that sometimes there is pathology only at the valve, but in most of the cases, when in the middle or in the distal part of the vein there is a stenosis on the valve, also stenosis is present. So I think that we have to take a look at all the vein, not only to concentrate to one place. My opinion is that predilective sites of stenosis are 3. Just below the bulbous, at the middle portion, and at the place of the valve.
I have a quick comment and question. The comment is, one thing else that might be important is that you two are treating very different, and we in the U.S. are treating very different patient populations with potential congenital, either valvular or venous abnormality. So the locations of these venous changes may be in different locations. So perhaps in Kuwait they're much less prevalent, just below the jugular frame. The question is, when you use the kissing cutting balloons, are you using 2 side by side?
Yes.
For
Yeah.
an effective diameter of 12 millimeters?
I have another case. because sometimes the bigger the balloon, less pressure can be done. So the rated burst pressure is very low. And in such case, when a very resistant stenosis is present, it's better to place two balloons side by side because they allow higher pressure, and the probability to dilate, to destroy the valve, is a little bigger. And in case of really resistant stenosis, they are very fibrotic stenosis. With the Doppler, we have seen place stenosis that and cases then in which the wall of the vein is twice bigger than the lumen, the wall. So it's not possible to be dilated with a simple balloon. You have to then scoring with additional wire besides a scoring balloon, cutting balloon, something else.
And just to answer, we're not treating different populations. The majority of my patients, 70, are actually not from Kuwait. They're from all over the world.
Thank you.
Thank you.